Sounds like they've almost worked through the technical issues.
Now are we ready?
Start talking anyway.
Okay. Good morning, everyone, and welcome to our bright and early edition of Research Meeting this week. I do not have any announcements, and neither does Amy. Before we get started with our MDisability interns, are there any announcements or anything that people on the call would like to share before we get started? There you go. Okay, I'm not seeing anything, so we will go ahead and get started. I'm going to hand it off to Mike.
Well, thank you everybody for showing up a half an hour early, and appreciate the patience as we were resolving some technical difficulties here. So I'm delighted to have our cohort, our next year's, this year's cohort of MDisability interns. I just want to let everybody know this is our largest group of interns that we've had, and really this was just an opportunity for us to collaborate with the Center for Disability Health and Wellness. And so this opportunity really came to be through the Advancing Health Equity for Adults with Disabilities from Diverse Communities Rehabilitation Research and Training Center that we have with the National Institutes of Disabilities, Independent Living, Rehabilitation Research. So we really appreciate that. And also for the MDisability summer internship, this also really was funded through our department. And so we appreciate the department's ongoing support and the philanthropy and different donors to support this program. So we have 5 excellent presentations coming up, and we're going to make sure we're on time so we can get through. They're going to all have their allotted time, and we also welcome questions from the audience as well. So, Akbar.
Good morning, everyone, both in person and on Zoom. It's a pleasure to be presenting the work I got to do this summer. I want to start off by saying thank you to my mentors and thank you for the opportunity to be a part of the MDisability cohort. My work this summer was multifaceted, but I'll talk mostly about my primary project, which is working with Dr. Tyler James on assessing HIV risk and prevention behavior among people with disabilities. So just an overview of what I'll talk about today, mostly focusing on my primary research, but I will touch on some of the amazing work I got to do in my secondary research projects. So who I am is a first-generation American military veteran and hopeful future physician. I just applied to medical school. And so my mission is to improve the lives of people with disabilities through empathetic clinical care and novel research. I think this summer has really clarified that part of this mission is advancing rehabilitation and health equity research to influence both my care and hopefully care across the country. Let's dive in. When thinking about HIV risk and prevention among people with disabilities, there is social context as well as the disability lens that is really important to look at. So I won't read all of these word for word, but the picture that's painted by these statistics is that people with disabilities face higher rates of STD diagnosis, poorer health outcomes, and poorer access to care. Now, these facts are harrowing and stark by themselves. But what's also interesting is that there are a few interventions that have been designed that account for these intersectionalities, the severity of disability and how that differs amongst populations, as well as the social determinants for health in this context of disability. And that's really what the research focused on. So overall, this primary research was within the context of equity relevant indicators, such as sexual orientation, household income, race, and stigma. We wanted to know whether disability status is associated with membership in groups that are at higher risk for STD diagnosis. So where did we turn for data? We utilized the National Survey on Drug Use and Health, or NISDA, which is a nationwide study that provides up-to-date information on tobacco, alcohol, drug use, as well as other social behaviors. Each year, NISDA interviews over 70,000 participants over the age of 12, and these reports are published nationally. So when it came to our study specifically, we were able to choose a sample size of around 44,000, and we chose 6 equity relevant indicators. And I'll talk a little bit more about why we chose these, but these are living in poverty, binge drinking, drug use, engagement with law enforcement, psychological distress, and then use of the emergency department. I've also talked a little bit about how these variables have been operationalized, but overall, these are really focused on within the last year or 30 days. The actual evaluation method was called latent class analysis, which is used to identify whether some of these indicators can create meta groups within the larger population. So going back to the discussion around these equity relevant indicators, we wanted to ground these choices in evidence-based theory. So we focused on 4 specific health behavior frameworks to influence our decision. But before I go into them, I think it's really important to emphasize that there is a limitation based on the data that the study provides. As much as we would love to choose optimal indicators that map exactly to these models, you're also limited just inherently by the products of these research studies. So the 4 models we chose was the social ecological model, which really talks about the interplay between and within the interpersonal and the community aspects, so both internal and external environments. The Anderson behavior model for health services use uses a flowchart approach to talk about why people decide to use healthcare resources. And it starts with their predisposing characteristics, some of the enabling resources around them, and then their perceived need for care. When it comes to someone's risk, Rhodes' environment framework was really helpful to understand it through the context of their physical, social, economic, and policy environments. And then syndemics was a theory that we utilized to really understand the interplay between multiple health conditions and how they can produce worse outcomes than if they were in isolation. All of these theories have been used in other research, and we decided to use these to map the indicators that we chose to this study. So when it comes to the evaluation framework, latent class analysis is a statistical method that uses that can create unobserved or latent classes within a larger heterogeneous population. So how this works is that individuals are assigned to these classes based on their interaction and responses to those equity relevant indicators. And then the classes that are produced represent a homogeneous group that share similar characteristics. According to Berlin et al., individuals within each class are most similar to each other and most distinct from other classes. That's the beauty of latent class analysis, that you can take a large heterogeneous population and bifurcate it into homogeneous groups based on behavior or risk profiles. So preliminary results, we're still ongoing, but for now, data suggests that 3 latent classes is the ideal fit for the large population. Within that, these are working titles for the classes. We're still thinking about how best to map them to the theoretical frameworks, but we have class 1, which is high substance use. So these are individuals who use substances to a high extent. Then you have deleterious equity relevant group. These are individuals who experience higher rates of negative social outcomes and social determinants of health. And then class 3 is the low risk / positive social determinants of health group. So these are individuals who have low use of drugs, alcohol, and then also low deleterious equity relevant groups. The data also suggests that people with disabilities are more likely to be part of the high substance use group or the deleterious, so class 1 or class 2, than people without disabilities. So diving a little further, these are three really important pieces of information. So the first one is the STD diagnosis. We conducted an odds ratio assessment and found that STD diagnosis, people who are in the high versus deleterious equity relevant group, high has a lower odds of being diagnosed with an STD, and this rate increases dramatically as you go from high versus positive or low risk versus deleterious, which has the highest odds of being diagnosed with an STD versus the low risk group. And then we can map that to the actual disability measures, and we find that being in these high substance use or deleterious classes, you have a higher odds of being in these classes if you have a disability. So using those two facts together, we can say that having a disability puts you at a higher odds of being in one of these equity relevant groups that then make you have a higher odds of having an STD. This graph on the right is a first attempt at visualizing the various classes and showing how they interplay, but then also how they differentiate from each other in regards to the rates of participation or action within the social relevant indicators. So overall, we're still figuring out the final naming convention for each class. We're hoping to further dive into those theoretical frameworks to organize these indicators graphically, and then we're completing drafting of the manuscript for journal submission. Now, I'd love to spend a ton of time on these two additional projects that I got to work on, but I want to call out Dr. Jody Schimmel-Hyde for her amazing work on the health and retirement study and really integrating me into that work. Overall, I had the opportunity to ask the question of whether we can use that data to determine whether there's a subset of population aging with versus aging into a disability. Much more work to be happening on this, but initial results show that there could be an opportunity here to differentiate using the HRS data. The other project was with CDHW and the Blue Cross Blue Shield of Michigan to do a grant evaluation on safety net organizations that received funding from Blue Cross Blue Shield and CDHW. We were able to dive deeper into these organizations' missions, identify methods of success measures, and we're in the process right now of setting up interviews with these organizations to really identify what worked and what are some opportunities for growth. It would not be a summer without these people, so I wanted to especially thank Dawn, Dr. Tyler James, Dr. Jody Schimmel-Hyde, my mentors, CDHW for the amazing work and the just really letting Faria and I run with our ideas, Dr. Mike McKee for his mentorship, Dr. O for his mentorship and his vulnerability in our coffee chats, and then the rest of the internship team had a fantastic cohort, and I could not ask for a better unit. And then MDisability, thank you for taking a chance on me, and I'm really grateful for this opportunity. I would now open it up for questions. Thank you.
We've got two questions on the chat, one which is possibly answered. Diane asks, is the NISDA self-reported? I responded that I believe it is self-reported, but confirmation would be nice.
I don't have the exact answer. From what I read was that it's a combination of self-report and then some interviews, but I would not have the exact answer.
But in terms of things like the emergency department.
Oh, yes. Okay, so those are all self-report.
Okay.
Yes, like binge drinking, those are all self.
And then Michelle Mead asks, how is disability operationalized? Does your population of people with disabilities include people with substance use disorders?
That's a great question. So within the NISDA, they have, again, self-report following the ACS criteria around disability. Further research is needed, and definitely a further question that we're hoping to work through is severity of disability and understanding whether that influences the odds ratios for both class assignment and also STD diagnosis. When it comes to substance use disorder and people with disability, I don't have an exact answer for that. So I'd say the answer is no. It's not. We're not including people that are suffering from substance use as someone with a disability. We're sticking to the ACS criteria for disability.
And I think there's a new comment, just a comment, not a question, that for one of your figures, a graph would be better as columns instead of a line chart. So,
We'll definitely play around with that. Thank you, Dr. Harper.
Okay, for this, we're gonna go ahead and move to the next one for time. So, if you wanna, go ahead, switch. Should be able to move to the next slide. Okay,
Everyone gets settled.
go ahead.
Hello.
Go ahead.
Hi, everyone, in person and online again. My name is Anna, and today I'll be discussing my primary project for the MDisability Internship, which is titled Advancing Deaf Obstetrical Equity, which stands for Adobe, developing the Adobe Toolkit. And this is led by the wonderful Dr. Kimberly McKee. So again, my name is Anna. I use she, her pronouns, and I'm an undergraduate here in the College of LSA on a pre-med track. I'm majoring in neuroscience, and I'm double minoring in Asian languages and cultures and disability studies. And as you might be able to tell, my areas of study have really taught me to look at health from an intersectional lens. And this made the Adobe project especially interesting to me, as we'll dive into today. So to understand why the Adobe Toolkit is needed, we first have to place it within the context of the maternal health crisis, and which we're currently experiencing. And this is consisting of severe maternal end mortality, which is a composite measure of 21 serious indicators of potentially life-threatening pregnancy-related and complications and deaths related to pregnancy and childbirth. And these outcomes have been rising in the United States. And the overall United States maternal death rate shown here is 22.3 deaths per 100,000 live births. And for Black women, the rate is 49.5, which is more than twice the overall rate and much higher than the rate shown for white, Hispanic, and Asian women. And these differences cannot be explained by individual medical conditions alone because structural and health system factors contribute greatly to this crisis. Deaf and hard of hearing patients can encounter autism, ableism, and mistrust within healthcare settings. Autism refers to the discrimination or assumptions that give privilege to hearing people and spoken communication. These experiences can make it harder for patients to feel respected, understood, or confident that their provider is even taking them seriously. There are also gaps in clinician knowledge and training, and there are limited birthing resources available in American Sign Language, and inconsistencies to access to a patient's preferred communication method. One example that highlights this is that the Alliance for Innovation on Maternal Health toolkits have been translated into more than 100 languages, but sadly, ASL is not one of them. When information is unavailable in an accessible language or format, patients may receive less information, receive it too late, or have even fewer opportunities to ask questions and make fully informed decisions. These inaccessible systems result in lower health literacy rates in this population that is not entirely due to a lack of interest or a lack of ability on the patient's side. Outcome data show that deaf and hard of hearing patients experience measurable disparities, especially at the intersection of disability and race. This graph compares the relative rates of severe maternal morbidity at delivery. White patients who are not deaf or hard of hearing serve as the baseline at 1, and the rate rises to 1.67 for white, deaf, and hard of hearing patients. The same pattern appears across racial groups. Black patients who are not deaf or hard of hearing have a relative rate of 1.98, while Black, deaf, and hard of hearing patients have the highest rate shown at 3.79. The takeaway is that disability and race compound risks, and a solution that considers only hearing status but ignores racism, or considers race but ignores communication access, will miss the patients experiencing the greatest risk. Given this identified disparity, a proposed solution is an obstetrical toolkit, which is a comprehensive set of resources designed to improve care. It should be evidence-based, action-oriented, and often standardized enough that patients and healthcare teams can use it consistently. A toolkit can include checklists, decision-making flowcharts, clinical protocols, and educational tools. The example on the slide is the Accessible Pregnancy Action Plan, and it organizes supports and planning across pregnancy, labor, and the postpartum period. The first goal of the Adobe Toolkit is to identify the leading indicators of severe maternal morbidity and mortality that contribute to inequities for DHH patients, including the particularly high risk faced by DHH Black patients. The second goal is to be informed by DHH patients themselves. The intended audience includes DHH birthing people, DHH Black people, Deaf Plus patients, patients with other intersecting identities, and the clinician and healthcare teams that care for them. Ultimately, the toolkit is meant to increase access to effective communication, strengthen fully informed decision-making, and support a more equitable perinatal care experience. The proposed content framework shows how patient experiences, system-level barriers, and clinical risks can be connected rather than addressed in isolation. And don't worry about reviewing everything on this chart, just focus on what's in the red text box and also what I described on the slide. So this diagram maps the proposed content framework across 3 areas, which are health system and clinician factors, patient interview probes, and Adobe domains. For this project, I focused on the curation of resources by exploring how existing maternal care resources targeted ableism, but also expands across the healthcare system and clinician factors listed on the left to inform Adobe clinician and patient materials. To decide what should be adapted and what still needed to be created, I reviewed maternal health and postpartum care resources and bundles for both patients and providers. I documented each in a report, which included a summary, whether the content was accessible for deaf and hard of hearing users, whether DHH and DHH Black experiences were represented, and how this toolkit was useful for Adobe. This review helped identify useful models that could be adapted, but also exposed current gaps in existing toolkits. One major finding was that postpartum care needs much more attention. About 40% of women do not attend a postpartum visit, and attendance is even lower among populations with limited resources. At the same time, about half of pregnancy-related deaths occur after birth. This is why the term ACOG, which is listed here on the bottom right, coined in order to emphasize the need for continued postpartum care. Care should be coordinated across a team, and accessible pregnancy action plans should be discussed before birth rather than introduced at discharge. Cardiovascular monitoring is also important before, during, and after pregnancy because cardiovascular disease causes up to half of maternal deaths, and about 2/3 of pregnancy-related cardiovascular deaths may be preventable. In addition, hypertensive disorders cause about 10%. Affect about 10% of pregnancies. Finally, I found that many otherwise useful resources were not digitally accessible and included outdated links. Ongoing maintenance is a key part of accessibility, and good toolkits need to be updated regularly. As for the next steps, I plan to stay involved with the project during the academic year and continue curating and evaluating resources to inform Adobe. Another major step is supporting ASL video content and graphical text materials, such as the supine position image here that communicates information more effectively in a modality that DHH patients might prefer, especially those with limited health knowledge. In addition to Adobe, I contributed to 2 other projects. The first was building an anti-ableist workplace at Michigan Medicine, led by Dr. Mike McKee, where I contributed to qualitative coding to help identify themes in our interviews and supported the development of interventions. I'm also planning a thematic analysis exploring the intersection of disability and international adoption. As for takeaways, I gained an introduction to mixed methods research, used Deduce for qualitative coding, improved my Qualtrics skills, and strengthened my literature reviews approaches and learned even more through the wonderful didactic series. I also gained clinical exposure through shadowing and got to see how barriers appear in real care settings that helped me connect to literature I was reading and patient experiences and understand why communication has to be planned for at a systemic level. Finally, I found a strong sense of community. I participated in volunteer opportunities, built relationships with faculty and staff mentors, and formed friendships with all my amazing interns. These experiences will shape how I approach my interest in medicine, research, and education in the future. I want to close by recognizing the teams and people who made this work possible. I would like to thank Dr. Kim McKee, who I know is on Zoom, Cynthia, Dr. Mike McKee, Dawn, Samya, Dr. O, Heidi, PF, Dr. Bentley, and the entire MDisability and CDHW teams, and also everyone here for listening, and I'm happy to answer any questions.
Are there questions from the audience here? I know there's one question from Dr. Harper. Anybody have a question?
I have a comment, if we'll accept comments. Something that I would encourage, this is something that Hannah and I have talked about, is the term Deaf Plus. It's used very frequently in grassroots deaf communities. I'll send you some resources. Dr. Octavian Robinson, a deaf disabled historian, has talked about the term being rooted in deaf people's attempt to distance themselves from the disability community, and has argued for the use of deaf disabled rather than deaf plus. But again, I recognize that it's also very much used by the deaf grassroots community, and so there's a give and take there.
Yeah, thank you for that.
Okay, Dr. Harper has a question. What is the reference for the SMMM raised among different populations?
The first one, or?
Yeah, for the first one, yeah.
This one was taken from the Commonwealth Fund, and it was primarily, as you can see here, supporting how the US continues to have the highest maternal death rate. But here it also exposed to how Black women by far have the highest disparity. And this graphic was chosen because Kim and I were actually going through what kind of graphic would be best supporting how describing the maternal health crisis, because as you could see here, there was preliminary research that her team did that looked specifically at DHH and race and ethnicity, but I know that included in the proposal, she didn't link directly to a graphic for the overall rates. And so this, I felt, kind of demonstrated why we're targeting DHH Black individuals specifically, and tied into the point that intersectionality is a key part of this population.
Yeah, and I believe your next slide is actually responding to Dr. Harper's comments. So that reference is the non-DHH white. I believe that with Dr. Harper's, she talking. Yeah, and also Dr. Kim McKee is also is confirming that is, yeah. So it's the non-disabled white is really the reference group.
Yeah, and to clarify if that's needed, so it might seem a little fragmented because the study is an explanatory sequential mixed methods research approach. And so actually this is only just a small sliver of the entire Adobe project. And I know Faria will talk about that later too, but basically there is 3 different aims, and aim 1 was essentially using quantitative statistics like this one to kind of look at the leading indicators of SMMM and also the magnitude and time of it, whereas aim 2 was qualitative, the qualitative side of it, which included interviews with DHH individuals and high representation from DHH Black individuals. So I believe there's 30 of them. That is not what I focused on. The other part of the qualitative process was this part, which was reviewing maternal care bundles and resources. And so the statistics are kind of informing both of them, but they're mostly informing the interviews and the probes that you might have seen on this slide. So that's why I didn't want you to focus too much on the other parts of it, because that's just another large part of the project, but not what I focused on for the presentation.
Great. Any other questions before we move on? Great. Well, thank you so much.
Thank you.
Appreciate it.
Morning, everyone. My name is Daignault, and my main mentor was Dr. Becky. Today, I am presenting on barriers, facilitators, and intersectionality of deaf, Black, Indigenous, and people of color, BIPOC parents. So I'm going to be focusing on my primary project. I'm also doing another project with Dr. McKee for biomarkers in deaf individuals of cognitive decline, and then with Dr. Tyler James, accessible health information resources for people with sensory disabilities. Unfortunately, we won't be able to cover everything with that. And then I also wanted to mention some of the skills that I've gained through the internship, reflexive thematic analysis, qualitative coding, and deduce, great literature review, and multiple disability perspectives that I gained through mentors and leaders here through our didactics and our faculty series. So for some of the background, we'll start with deaf identities. Deaf with big D represents people that have shared language, culture, and community, whereas people that are deaf with little d more representative of audiological status. So typically someone doesn't sign or they're oral, and they usually do not have a big connection with the deaf community. Someone who is hard of hearing normally has mild hearing loss, but sometimes they do identify as culturally deaf if they're largely connected with the deaf community, and also signs are part of the culture. So general parenting disparities. Parenting disparities are systemic barriers that prevent parents from accessing resources for themselves and their children. So this could be socioeconomic status and financial stability, healthcare access and quality, educational access and the quality of the education, the local community, the cultural context, and then the built environment and their neighborhoods. So specifically for deaf disparities, deaf people face autism, which is the belief that hearing status or being hearing is superior to having hearing loss or being deaf. And this also prioritizes oral languages over sign languages. There is a systemic lack of language access among deaf populations and an overall lack of cultural awareness among majority of the population, which is the hearing population. Due to marginalization, deaf people face a limited amount of incidental learning opportunities. And an example of this is dinner table syndrome, which is shown in the image to the right. This is by deaf artist Nancy Moore from Manchester. So dinner table syndrome is basically when you are not included in conversations because the people around you do not know your language. This is really common for deaf people because majority of deaf people are born into hearing families, and many hearing families do not learn sign languages or want their children to try to learn oral languages or do their best to hear or speech read. So this really limits the access that deaf people have to learning from their families. So specifically for deaf parenting disparities, deaf parents are disproportionately likely to lack social support, and they also have an increase of interpersonal violence, marital discord, and an accessible legal system with the court system, more likely to deal with issues with CPS. There is also a significant gap in health and navigational literacy, and that is largely due to table syndrome as well as not having resources available in American Sign Language. I wanted to also provide a slide on deaf, Black, Indigenous, and people of color BIPOC parents and their specific deaf parenting disparities, but this is extremely limited for the published research, which is why I thought this was really important to investigate. So for methods, For the data sources, they looked at the prior qualitative exploratory study, which examined the parenting experiences of 20 deaf and hard of hearing parents across the United States. This was focused on their successes, their barriers, their facilitators, and access to parenting related resources. The exploratory project conducted was to examine the experiences of BIPOC deaf parents. Within the sample, there were 7 identified BIPOC participants versus those who were non-BIPOC. So the lens that I was looking at this through was the intersectionality theory within by Kimberly Crenshaw. She is a lawyer within Columbia. She coined the term intersectionality in 1989. And this is the intersection of social identities. Hers was initially focused on race and sex, but she wanted to talk about social identities in the context of the identities overlapping and how these combine to create a distinct experience of oppression and or privilege for people. Single access framing is really common, and this embraces one identity for another, and it lacks the nuance of converging identities and how this emerges for unique experiences for people. So the participants, there were 20 deaf parents who used ASL as their primary language, 7 BIPOC participants, 13 white. The criteria were that parents had to be at least 18 years old, they had to have a child who was 13 or under, and they needed to reside in the United States. For the design, there was a qualitative study examining parents' experiences of deaf ASL sires, navigating parenting in medical, educational, and legal systems and how this impacted parenting outcomes. Data was collected through semi-structured remote interviews, and they were asked about access to parenting information, resources, and their communication access. I did a SAM analysis, so I reviewed the previously analyzed transcripts and deduced. I did a reflexive thematic analysis, and I compared recurring themes in white deaf and BIPOC deaf parents. I identified emerging themes that are unique to deaf BIPOC parents and then performed a great literature review, but this was more just supportive for the discussion, and this was to also support the intersectional lens for analysis. So for the results, there were some universal themes amongst all deaf parents. Every single participant had an experience with barriers to language access. All reported a lack of interpreters, whether it was in the medical field, educational system, or legal setting. Some of the most that stood out were birthing people described not having interpreters during their births. So even if they had set up interpreters prior, birth is unpredictable. So sometimes interpreters could not be there immediately. Sometimes there are access issues with VRI, which is the virtual interpreting. Or there were interpreters that were able to make it in time, and there were a lot of situations where people were trying to self-advocate at the same time while also trying to give birth. There were limited resources and support. Several participants reported using AI or other deaf parents for information because professional resources were not available in ASL. Family dynamics function both as barriers and facilitators. So for some people, their spouse and their own family, their own parents were really supportive. This gave them a cultural connection. People that they trusted to watch their children and give advice. But for many deaf people, they are cut off from their hearing families because they don't have the same culture, they don't have the same language. So this also functioned as a barrier for others and for others as well as this marital discord. And then in addition, BIPOC parents faced additional barriers. So some of the intersectional experiences, BIPOC parents reported wondering when they did face oppression if it was due to being deaf, BIPOC, or both. Participant 23 shared, they ignored my son because his ASL is not like theirs. Instead of judging others on their deafness, their generation, their families, or their school, am I not white enough or what? My son is not enough to be a coda. That is enough. So this participant is explaining something called deaf elitism. The deaf community is a small community. And even within the community, there is sometimes judgment on who is deaf enough. If you come from a deaf family, you can be considered more culturally deaf versus someone that comes from a hearing family, even though this is the majority of deaf people. And then she also had worries that because she was Hispanic and her son was Hispanic, maybe it wasn't because they were deaf, it was because they weren't white enough. The Facebook racism and autism, one Black father, participant 19, shared that he's a deaf parent. When his child started school, the school gave him a form for those who need food for free for every month. They thought I couldn't afford it, so I refused because I could take care of it. They asked if I needed a bus. I denied one because I could drive. Those things, they thought I can't. No, I can't, just like others. So there was an assumption that a Black deaf father would not be able to afford food every month, and also that he could not drive. It's a very common belief among hearing people that deaf people cannot drive. Participant 3 shared about moving to a new city when her son was 2 months old. She had met a white woman who took the time to write down on a note that really disappointed her. She said, I still have it in my file. It stated that it's important for parents to speak in English. I explained to her that my son knows ASL, but she undervalued my language. This participant also, for some additional context, her son actually speaks Spanish, English, and signs ASL, all 3 languages fluently. But they continue to describe in their interview people believing that this was not enough because she herself did not speak English. Participant 13, this is regarding IEPs. They were sharing that it's even more challenging for children of color to access IEPs. For instance, a friend of mine, I recommended they contact the Disability Resource Center and provided them with a number. They've been involved with the IEP process for a long time, but they still feel stuck. So yeah, that definitely highlights the significant gap in resources and support. So discussion and conclusions, again, Kimberly Crenshaw. Imagine an intersection where traffic flows about 4 directions. A person standing in the middle can be hit from any side. So this is just highlighting the fact that many people are navigating more than just the 2 worlds of being hearing and deaf, especially BIPOC parents. They're navigating a white hearing world, a white deaf world, a hearing BIPOC world, and a deaf BIPOC world. And in addition to this, deaf BIPOC parents have to guard their children from multiple forms of discrimination because of these intersecting identities. So peer networks function as a protective factor for deaf parents. As it was shared with the participant 13 earlier, she functioned as a peer network for another Black deaf parent. And this is because they were not gaining access for their IEPs. And this is something that's very common for deaf people, is to help each other out with how something was successful for them. They work with other deaf parents and peers to make sure that they can have successes. And deaf people who utilize peer networks for information have been shown to have higher levels of critical health literacy. And this is even with deaf people that have these conversations with their families. That was not shown to have a higher level of health literacy. It was really through the deaf peer networks. So for limitations, this is a sub-analysis. The initial focus of the research was not on BIPOC disparities or barriers of facilitators. So some of the questions were as pointed as they would be if this was the main research. The sample size was small, and majority of the participants were white. In conclusion, and for future steps, it would be ideal to do like a more probing interview with more targeted questions for BIPOC parents. More cultural awareness and education for medical providers, teachers, and legal experts to understand some of the barriers that deaf people are facing. Developing ASL specific resources as this continued to come up as a universal theme. And then engaging with BIPOC communities to expand resources that are acceptable culturally and understanding the intersectionality of them experiencing more than one experience of the social identity. And then I wanted to thank and acknowledge the deaf community and the research participants in the study. My mentors, Dr. McKee and Dr. James, Dr. O, CDHW, and MDisability, Don Michael, and then my fellow interns. Thank you very much. Any questions?
So there's questions online. First question was, what community did you interact to find BIPOC deaf participants? I know.
I went to an Indigenous symposium that there were some presentations on being deaf and Indigenous. That was where it occurred the most, where I was seeing discussions where people were feeling isolated from multiple communities, and that it was continuous throughout, that people were struggling with access to their communities and their culture. As far as like the literature review, most of the literature was on Black deaf parents. As far as the actual participants, there were 2 Asian, 3 Hispanic, and I believe 4 Black deaf parents.
Yeah, and I think they were also talking about the recruitment for the study itself.
Um,
So just a comment quickly for Dr. Harper. So we were able to rely on different deaf organization, diverse organizations, and also we have kind of built some trust with a variety of partners and our advisory board. So just to add, I know you're analyzing it, so okay. Last one is, how would you get a parent on what resources they need? Because there was that concern about assuming that they were poor, they couldn't drive. How would you contact parents?
I think it would be the same way that you would ask a hearing parent that they have resources. If that's something that's advertised by the school, just making sure that it's accessible for them in ASL. I don't think the approach would really be different as long as it had language access. That's my opinion.
How to standardize it?
Yeah.
Agree. Thank you.
Thank you.
My computer is about to die, so Lori, maybe Dawn, if you can monitor the chat. Unfortunately, my computer's giving out. So. Oh, with our Mac. Oh, okay. It's up to you. Okay. Thank you.
Okay. Hi, everyone. First off, I just want to share my appreciation for all of you to listening in to each of our presentations. We all have worked really hard on them, and so it's great and exciting for all of us to be able to share that work with you. So my name is Ashlyn Perry. I am super thrilled to share some of the work I've been doing with the Move Together initiative alongside Dr. Faria Tavacoli and Dr. Haley Miller. I'll start with a brief introduction of who I am and why this is what interests me, share a little bit about Move Together and some brief history behind it, the types of community engagement work I've been involved in, a little bit about the actual Move Together content, and then moving forward with Move Together. So I'm a rising senior in the Movement Science Honors Program here in the U of M School of Kinesiology. I'm also minoring in Disability Studies. In terms of research experience, I worked in the Motor and Visual Development Lab for the past several years, along with some of these community organizations local to Ann Arbor, Michigan, some of them internationally, and all of them have provided skills, knowledge, and relationships that have really formed my understanding of disability and movement in general and my desire to engage with this work. Ooh, sorry, wrong way. So Move Together is an accessible, modular, online training Canvas curriculum, which aims to prepare students to volunteer in adapted and inclusive movement-based programming. The goal is really to provide foundational knowledge and practical guidance on disability inclusion, communication, safety, program adaptation, amongst other topics. So my role as an intern has been to develop, implement, and then evaluate this curriculum. So why Move Together? That is because few structured trainings currently exist for students who are engaging with these movement-based settings and disabled participants. And so we aim to create structured training which can improve program quality and enhance learner outcomes. Disability education and service learning experiences can also shift attitudes, streamline the onboarding process, and we can create kind of a uniform standard to benefit volunteers and adaptive sport organizations according to evidence-based practices. The Move Together team is highly collaborative, and so I want to highlight that. This is folks across the School of Kinesiology, Applied Exercise Science, Movement Science, Student Accessibility and Accommodation Services, Adaptive Sports and Fitness, Family Medicine, and Physical Medicine and Rehabilitation. Don't worry about reading everything on this slide, but I wanted to provide a brief kind of background history. I have been more involved this spring, but the Adaptive Sport and Rec Working Group really started back in fall 2024 with this idea to propose a curriculum collaboration amongst these faculty and understand existing resources for some of the training opportunities for these programs. So then in 2025, Dr. Haley Miller proposed a grant submission. The Adaptive Sport and Rec Working Group reached out to schools, programs, organizations, and generated a tentative modules list, which is what I'll be sharing more about with you. The grant was eventually awarded. I was brought on as an intern, and I've continued community engagement efforts, seeking feedback about resources, accessibility, and a variety of other topics. And then throughout this internship, I've been focused on training with the Kids Sport Adaptive summer camp programming through kinesiology community programs. We've piloted one of the curriculum, some of the modules, and then proposed a module extension along with engage further with some health profession students, the lead programming, and then of course meeting with coaches, staff, and faculty with adaptive sports and fitness. Community input has been incredibly helpful and important in this work. So this is a kind of long list, but not extensive, of all of the community organizations I've been in touch with and reached out to, either in person or virtually. So lead programming, like I said, with the M1s, that would be with Dr. O throughout the summer. Special Olympics, Unified and State Games, along with healthy athlete screenings. The Motor and Visual Development Lab has a community advisory team comprised of 8 to 12 neurodivergent adults. And so I had the opportunity to present some of this work with them and discuss what types of features on these pages would be important, what types of language do we want to use or avoid, details such as those. UMAs, CDHW, Best Buddies International, and then kinesiology undergrad and graduate students. This is a long modules list. I just want us to focus on 3 of them. So beginning with the first one, disability justice, universal design, and allyship. I just want to highlight that the curriculum is not only sport specific. We really aim to give learners the opportunity to feel engaged and a part of the disabilities community in whatever way they would like. So we're providing context to disability culture, theory, different models of disability, all of that. And then moving on to the adaptive equipment and technology section, that would be more sport-specific type information, but still generalized to different types of equipment that someone might use to engage in any type of exercise programming. And then going on to the sport-specific guidelines and techniques, this is really an opportunity for folks to dive into the specific activities that they might engage with in a specific setting. So if you're going to volunteer with ASF and you're going to go play wheelchair basketball, you might want to review the wheelchair basketball section, learn the rules, learn different types of classifications, the types of equipment or chairs that would be used in that specific setting. This is more of a visual of the modules list. It is supposed to scroll down. It would show you that the pages would open up, and there's about 5 to 7 on each module. This one is also supposed to scroll and show you that as you click on each of these buttons, more information would open up. This is a picture of the homepage of the Move Together curriculum. And as we scroll down, it would show the different U of M organizations that are involved in this work. And so while the curriculum is built and will hopefully be expanded beyond U of M, the goal is to also include U of M community members in what currently exists and make sure people are aware of that. In terms of resources, a wide variety of resources have been used for this work. So this is not an extensive list, but community members first and foremost. That would be other students, volunteers, athletes, caregivers, parents, self-advocates, the Canvas Global Accessibility Team, the MVD Lab team, Kids Sport Adaptive resources, and then of course the Adaptive Sport and Rec Working Group faculty, and just communicating with those who are already involved with this work here. In terms of the Kids Sport Adaptive pilot curriculum, we have created or have extended some of the surveys that already exist for that group. We looked at factors such as prior experience, familiarity with disability-related topics, knowledge gaps, attitudes, confidence, questions such as those. I've also engaged with the in-person training alongside Dr. Miller, Carrie Winkleseth, and Jody Ty in kinesiology, and then have been at camp to follow up throughout the summer and really understand, are the training objectives that we created benefiting the learners or the counselors in this case, engaging with these kiddos, what else could be added, what gaps might they feel could be filled in and added to this curriculum. And then in terms of specific additions that we've made since the start, we created a dedication communication module. So that would be communication with participants, communication with coaches, faculty, supervisors, fellow counselors, fellow volunteers, common terms and definitions, because I kind of noticed I was using a lot of language throughout and not everyone knew what those terms meant. So it's really important that we kind of define that for folks. Professionals that people might interact with, adapted PE teachers, rec therapists, researchers, all those types of people. Movement science, not only because I like it and it's my major, but also because I think it's important that people understand why movement and exercise is really so important for all individuals, disabled or not. And then access to adaptive sport, because of course we have a lot of great programming here at U of M, but it's important to ensure that people are aware that that is not always an opportunity, or adaptive sports aren't something that everyone currently has access to. Accessibility considerations have also been very important. So screen reader compatibility has already been tested and will continue to be throughout the development process. We've also looked at text, font, size, and color, looking at avoiding flashing images in certain contexts, making sure we provide all text for all images, captioning for videos, transcripts when necessary, considering moving or interactive features, and all of these are things that our community advisory team has brought up as well. And then in terms of the actual curriculum, we want to make sure it's accessible for a variety of learners and volunteers with varying levels of adaptive sport experiences and readiness. Personal experiences with disability or within the disability community are also important considerations. In terms of a program-specific page, this would scroll down and show you that for an ASF, there would be different modules or buttons that folks could click on: wheelchair rugby, wheelchair basketball, para powerlifting, sports such as those. And then scrolling down a bit more, there would be more event-specific information. So the Miller Family Open was a recent adaptive track and field meet. And so we went to that specific page. It would show you more tailored training and people could ask questions. They would have the address, the photo release form, basically kind of centralizing the information that might typically go on emails, or different training links would all be in one place for people to access. So moving forward with Move Together, we have drafted and proposed a module extension for health profession students, and that would be information about the benefits to prescribing adaptive movement. That would be connecting professionals with emerging professionals with existing adaptive sport offerings in the community. And this is really important because disability-focused education can shift attitudes, strengthen self-efficacy, and promote empathy in kinesiology and health profession students. Also because adaptive sport exposure amongst providers can improve comfort and confidence in treating patients with disabilities. And it helps to ensure that disabled individuals have access to adaptive sport and rec opportunities beyond just physical health reasons. Adaptive sports offers a great community. I've had the opportunity to be engaged with a lot of these program opportunities for more than just physical health reasons as well. And so I feel strongly that this is something that all kinesiology students and future health profession workers should be a part of. And so as I continue in this work, we will complete the KSIA post-camp survey. So that would be for Kids Sport Adaptive summer camps, and the pilot curriculum. We'll ensure that we add additional adaptive sport programming and are continuing to develop the sport-specific content alongside coaches. We will add assessment and self-check exercises so that we're able to more effectively track who has gone through each module, when, how long they spent on it, and just ensuring that people are actually taking in the information. Continued community engagement efforts and feedback to ensure accessibility, and that this curriculum is something that would be practical and usable in this community. And then the Adaptive Sport and Rec Working Group will continue to meet. All of the faculty I showed you earlier are incredibly dedicated to this work, and we will make sure that everyone is involved and the programs are able to use this together. So I just want to extend a big thank you to Dawn, Dr. O, Dr. McKee, Dr. Miller. U of M Adaptive Sports and Fitness coaches and the Student Accessibility and Accommodations team has been incredibly helpful this summer. The Adaptive Sport and Rec Working Group members have spent lots of time reviewing this, providing feedback, and talking through different changes we can make. All the faculty series presenters, and then CDHW and the MDisability community. And of course, my fellow interns, Hannah, Anna, Akbar, and Faria, for being such a highly motivated and dedicated group. So happy to answer any questions.
Thank you, Ashlyn. So there is one question, and this may have already been addressed But Dr. Monkman does have a question. What students are we referring to? And I know you went through different programs, K to 12, college.
That's a great question. So currently college students, I think the hope is that once we have this initial curriculum developed, that we would be able to kind of extend it for different age groups and whatnot. But currently it's health professions that would be undergrad students, so KNEs, pre-PA, PT, any kind of student who's going that healthcare route, any community member, I would say college age or older, high schoolers, kind of who would this content would be applicable or relevant for. And then also like M1s is who we've been talking to, so incoming first year medical students as well.
Any other questions? Yeah.
I just want to ask, so the photo in the pool, is that an like a printed AAC?
Yeah, can I see the keyboard, please?
A printed AAC on a pool float?
Oh yeah, I can do that. Yeah, sorry, I can go back. Yes, so for some of our campers, we were able to use a variety of communication devices and styles outside of the water. And when we got into the pool, we were always like, well, what do we do? Like, you can't put an iPad in the pool. Sometimes higher technology like isn't the best. You kind of just want to communicate whatever way works best. And so we were like, if we laminate something that we print and then you kind of put a little water behind the kickboard here, then it sticks to it. And then we were able to point to it. And we've done that with name tag cards that I didn't put up here, but we had about 15 to 20 cards that every counselor has on their tag. And so they can flip through it. Kids can flip through it if they want. And then we also have like whiteboard magnets. So a wide variety of ways, but we didn't want magnets in the water and other safety concerns. So this was the solution we came up with.
May I ask, do you know what that kiddo uses for typical communication? Are they using an iPad like PEX system, or are they using a more printed manual system?
Yeah, so this kiddo was using a more printed manual system, if I'm remembering correctly. Some of the folks that come in, they like are learning to use other devices, but in terms of counselors as well, like not every Pittsburgh counselor has extensive experience with like a PEX card system and whatnot. So sometimes it's also finding a good fit for like how does each counselor, how can they effectively communicate with the camper and whatnot. So sometimes it's just more safety, like practical reasons they can point. Other times it is to like further develop their communication if that's a goal that they have.
No, that's genius. Thank you.
Yeah, thank you, Ashlyn. Okay, we're going to now switch over to Faria. Faria is going to present online. Just make sure we get that set. Just to let everybody in the audience here, if you are able to pin Faria, she is online. Faria, hopefully you can see us here. Okay, great.
Can everyone hear me as well? Can I take that as a yes? Oh, okay, beautiful. Awesome. So I'm going to start now, if that's okay, but hi everyone, I hope you're having a wonderful Tuesday. My name is Faria Tavacoli, and I am just going to be sharing, last but not least, on my MDisability summer research experience. Next slide. Awesome. So this is just a little agenda. I'm going to share a little bit about myself and focus on 2 projects that I had the wonderful opportunity to do this summer and what would possibly be next afterwards. Next slide. So just a little bit about me, if we already haven't been introduced. I am a first-generation student at the University of Nevada, Las Vegas. I'm double majored in public health and neuroscience, and I would say a lot of like my academic and professional interests are really surrounded on the ideas of disability health and health equity and accessibility, just from my own health conditions, but also being a caregiver for my dad who has some severe health conditions as well. And I think it's been carrying forward throughout a lot of what I focus on in Las Vegas. And I always share this as a fun fact, but I always say, like, I used to competitively skateboard, and as much as it can get redundant, I think it has really taught me a lot about, like, trying even after falling, which is a lesson that has also helped me within this program and the research experience. Next slide. So the first project I just want to talk about is my scoping review that I had the wonderful opportunity to do with Dr. Brandley Bentley and Dr. Kim McKee. And the project is connected to the Advancing Deaf Obstetrical Equity Initiative, also known as Adobe, that Anna had talked about as well. Next slide. So before discussing the review in itself, I just wanted to provide some background in regards to why this topic obviously is important. So deaf or hard of hearing has been referred to any degree of permanent or fluctuating hearing loss. And we also know that existing research has identified significant maternal health disparities that affect deaf and or hard of hearing individuals. In particular, they experience approximately 80% higher risk of severe maternal morbidity compared with individuals who are not deaf or hard of hearing. But we also see how these disparities become way even greater when we consider the intersecting identities, with Black, deaf, or hard of hearing individuals experiencing about 4 times greater risk compared to non-deaf of hard of hearing and white individuals, which it's really truly demonstrating why it's so important to examine both disability and racial disparities within maternal health care, and is really a foundation of Adobe, which is aiming to develop these accessible avenues for an obstetrical toolkit to provide more equitable care for deaf or hard of hearing populations. Next slide. And as such, the idea of focusing on deaf or hard of hearing and Black birthing individuals is important because we see such avenues of maternal health outcomes that exist within both populations, such as deaf or hard of hearing individuals experiencing gestational diabetes, preeclampsia, and even postpartum hospitalizations. And the research for Black birthing individuals is also showing a lot of these disparities as well, with severe maternal morbidity and mortality, preterm birth, low birth weight, but also postpartum complications. And ultimately, it's because these bodies of literature are studied separately, we understand how it's difficult to really comprehensively take into consideration the experiences of individuals who are both Black and deaf or hard of hearing. So by examining both populations, it's under the goal of trying to identify what is already known, but also where the significant gaps also remain. Next slide. And that is why the objective of this scoping review is to really synthesize on the existing literature of maternal health outcomes for Black birthing individuals, deaf or hard of hearing birthing individuals, but also Black and deaf or hard of hearing birthing individuals. And ultimately identifying those gaps and understanding the existing evidence will allow for informing the development of the Adobe toolkit. Next slide. And this is just a little schematic of how the literature search is divided into these 3 connecting areas. So the first area is obviously collecting maternal health outcome literature for deaf or hard of hearing birthing individuals. The second is for Black birthing individuals. And then the third is specifically for Black and deaf or hard of hearing birthing individuals. And one of the major questions we actually had in this process is whether Black and deaf or hard of hearing birthing individuals are meaningfully represented in the current literature, which unfortunately they are not. But collecting the themes and the discrete information that is within this literature will be important for us to see whether there are certain information and contexts that can overlap. Next slide. In terms of like our search methodology, we're following the JBI scoping review methodology, and then hopefully plan to report the scoping review utilizing the PRISMA guidelines. And we are hoping to be expansive in this search with multiple databases such as PubMed, Embase, and all, Web of Science, and PsycInfo, and we want to see how these databases can capture projects that are in like multiple fields, and within the search strategy also have controlled vocabulary and keywords relating to the populations. And that can include things like perinatal care, postnatal care, and just maternal health outcomes and experiences. Next slide. In terms of our screening methodology, we also worked on making inclusion and exclusion criteria, focusing on like examining things like pregnancy, childbirth, postpartum care, or even like related maternal, fetal, neonatal, and perinatal outcomes, and then also including research that examines like healthcare access and communication accommodations with patient experiences, because we also understand that maternal health isn't limited just to these like clinical outcomes alone, and the accessibility is also a key important part. And we plan to create parameters where it focuses on original research published in English within the past 20 years. Obviously, like in this scoping review, we're not considering like reviews or other types of protocols or case reports, and we want to ensure that the included evidence and knowledge that comes from the scoping review directly contributes to the questions we're trying to answer. So next slide. In terms of current progress, we have refined kind of the protocol and inclusion-exclusion criteria, but we're also meeting with an informatician because this is a very new way of thinking about a scoping review, and we want to see how we can flesh this idea out further. Next slide. And then I'm going to talk lightly about the CDHW Grant Evaluation Project, which we have gotten support from with Dr. Mead, and then Akbar as well, who has talked about this as well. Next slide. So essentially we are doing an evaluation of these grants that were given by Blue Cross Blue Shield of Michigan and CDHW in terms of seeing how the accessibility and equity of their organizations has increased once given a grant, and seeing how their project implementation has worked out, and how we can create a framework to evaluate future organizations that are getting funded from CDHW and Blue Cross Blue Shield. Next slide. So we're really grateful that we have survey questions drafted and sent for review, and as Akbar mentioned, we're scheduling calls with organizations to ask for their feedback on how this experience was for them and what they would like to see moving forward with kind of this process as well. Next slide. So I would like to just say, like, overall, the skills that have been gained throughout the experience has been super meaningful. I think whether that is focusing on the review methodology or looking through certain evaluation methods or frameworks has been incredibly important in my perspective, and I think really relates to not only how do we advocate for disability access, but how do we explain it as well. And looking ahead, I'm really excited to continue on with these projects and really gain more insights from the amazing faculty that is at UMich. Next slide. So I just want to say this is not an exhaustive list, but thank you so much to the people that made this program work, especially being remote for this program. And I could not thank you enough for allowing me to continue, and we'll carry it forward, hopefully from there. But if there are any questions, I can answer some. But thank you again for all your support and guidance throughout this summer.
You didn't give me.
Yeah, you should be muted.
Okay, all right, hopefully you can hear us. There is one question in the chat, and if you can also see it. For those doing intersecting theories, the journals are asking that use Evans statistical models of MATA, which I had to look up. It's multi-level analysis of heterogeneity and non-discriminatory action or analysis for just a note that is now being required, and it can be a little bit complicated. So I appreciate it. I think that's more of a comment. I don't know if you have anything to add. And that's from Dr. Harper.
Just a comment, as we've had to redo some of our analyses in a paper that is hopefully going to be submitted after they're done.
All right, thank you, Dr. Harper. I appreciate that. Are there any other questions from the audience?
What are some of the findings that you've seen so far, or trends that you've seen in not necessarily, I guess, the scoping review, depending on how far you're into it, but just kind of what are the key takeaways that you've gotten so far from the literature?
Great question, Anna. And I think it's just similar to kind of what we're seeing about the intersecting identities creating more disparities in terms of health outcomes. But unfortunately, I will say that the scoping review did shift away from our original idea of just focusing on deaf or hard of hearing and birthing individuals, because we saw that there was like a published like scoping review done in regards to that. So we added the racial component onto it because we also noticed within the literature that a lot of it in terms of maternal health for Black birthing individuals focuses on racism, but it doesn't focus like on the discrete maternal health disparities that exist for them. And I think doing like a layered scoping review would be important, just to see how like thematically they intersect with one another. But we haven't gotten to that point yet, but I'm excited to get to that point once we meet with the implementation tomorrow to gain more like guidance and like direction.
Awesome, thank you. Good luck.
All right, we have another question.
Yeah, this is Tyler speaking. I had a quick question with respect to Anna's question, so kind of following up. Are you planning on contacting the authors of some of the studies that are going to be included? I'm just thinking of my own qualitative studies that I've published in Deaf Health. I have not reported the race of the participant with the quote. And so I'm wondering that like there might be an absence of that evidence that you're looking for, but it actually exists, whether it's in the transcripts and not reported in a manuscript. Are you planning on contacting the primary authors?
This is such a good question because we actually talked about like data being disaggregated and not being like presently shown, and if we're missing that, I think that would be a really great thing to do. And personally, I'll reach out to you, Dr. James, if that's okay. But we definitely did talk about this, about like how a lot of these research teams, we are aware of them, but like their report in itself isn't necessarily showing like the racial categories, for example.
Thank you.
Well, thank you, everybody. I know we're getting close to the end here. I just want to just spend a couple minutes thanking everybody who's been involved with this summer internship. I mean, obviously, this is a team effort, and it's an important component of really just helping to increase opportunities to have obviously individuals, trainees with different types of disabilities or interests in disability health to be able to continue on and make an impact in their respective fields. So I know many of us here in our department and also even other departments such as PMR and even OB and other departments were really key as being a component of this, whether through their mentorship or even being willing to present as part of their faculty didactic series. We also had some of our staff members also be part of that as well. And thank you for Dawn, also really just helping to coordinate everything. So appreciate carving out some time today to hear the wonderful work that everybody's doing. So thank you again.
And I would just like to say this has been one of the most engaged, awesome, and incredible cohorts. And just their work is really tremendous. And it's been a wonderful summer. So thank you to all of the interns too. It's been great working with all of you this summer. Thank you,
Thank you for the interpreters. Appreciate it. All right. Thank you, everybody.
Please check your text message for post interviews.
Good.
Thank you. Thank you, Josh.
We're all set. Thank you, everyone.